the follow-up. You see, it started from 1986 to 2003. All the publication, everything on cryo-ROP is between that period. And that is what we have learned so many lessons. So another lesson, once these were followed up, the problem was the visual acuity. The visual acuity was not that great. In fact, 3.5 years, or some of us, we remember, when that publication came, we became so depressed. I'm sure Gopal must remember. That control eye had a better than 20/40 vision, that is 6/12 vision, more number of them, and only 13% probably in cases of, so it was thought there is something wrong. But in 5.5 years, that was reversed and the things were all right. And second, the thing was not only that we learned about this, we also learned that the vitreous surgery, which they did for those babies that time, I think only 2 babies got pattern vision, and which also was lost once they were followed for a longer time. So there was more aspect on that we should be treating them early, and that's how came the ETROM. And other things was, they pointed out during follow-up lot of sequelae. So that was a problem. That's another one we learned. Threshold ROP leads to more, so we don't even need to know now threshold ROP. Those 5, we were all the time counting 5 continuous or 8 contiguous hours of stage we wanted to with plus disease. We used to wait, and that's why we got sequelae in many of those, which we don't do today. So I think we learned many things. Of course, then they developed myopia, substantial number of them. So I think we learned so many things, and this study is a landmark, and this is what has given way for the ROP management as well as the whole thing. Even I have not talked about the natural history. That is another one that showed us.
I think just to emphasize the point, the cryo-ROP study is the beginning of the way we treat ROP babies, but doesn't mean we follow those criteria now, because we don't wait for threshold as defined in the cryo-ROP study. We don't use cryo, we use laser, because with laser the efficacy as well is equal, but the visual results are much better, etc., etc. But I think there are a few points to take home from cryo-ROP study. One is, of course, the efficacy of the ablative treatment. The other is that most babies who required treatment or who went into threshold ROP also had higher risk of comorbidities, which tells you that the parents have to be mentally prepared for sometimes other problems as well. Okay, many of them had neurosurgery for shunts, etc., and had other comorbidities. And again, there is increased risk of myopia, increased risk of field loss because of the ablative treatment. That became the arguing point for anti-VEGF by the beta ROP study, saying we don't destroy any retina, you preserve every bit of retina. And then in the natural course has also shown that more than 1250 grams birth weight children have almost always had universally a good result. Hardly about 2.1% had a poor result with more than 1250 grams. This is in the United States. May not be applicable to India as of today. Hopefully we reverse this trend in the future. Okay. This is basically in brief about the cryo-ROP study. So these are lessons from it which we take forwards, and we have dispensed away with the threshold ROP as a limiting criteria for treatment. So what do we have as criteria for treatment, Dr. Karovi?
The pre-threshold disease has been divided by the ETROP study into a type 1 and a type 2 disease. Now the type 1 is a high risk unfavorable, which is greater than 15%, where it is zone 1, any stage with plus disease, zone 1, stage 3 without plus, and zone 2, stage 2 or 3 with plus disease. Now this subgroup is very important, because if you pick up these children at the inception, the results are much better. And the thing is that the type 2 is the low risk favorable, which is less than 15%, which is zone 1, stage 1 or 2 without plus, and zone 2, stage 3 without plus. So the ETROP guidelines say that if you pick up patients at pre-threshold and treat them, if you see any of these conditions, it would be much more advantageous in controlling the disease. So these are few of the examples. Next.
Go next slide. Okay.
Not this. This is iris new vessels and the posterior pole. Yes, these are certain patients. So earlier to this also.
Earlier there is nothing else. This is the one.
Okay, then I think after this.
I think that slide is missing.
Doesn't matter.
Okay. Go ahead.
That's it. No.
You can also talk about APROP.
When we talk about APROP, what is APROP? APROP is aggressive posterior ROP. This is the most fulminant form of ROP, and hence it was earlier called as rush disease, fulminant ROP, type 2 ROP, but now it is called as APROP. This is a disease which generally affects zone 1 or 2, that is affects the posterior pole. It affects generally very, very lower birth weight babies. And there are iris new vessels sometimes seen on the iris as well, and the active tunicovasculosa lentis creeping onto the surface of the lens as you see in the slide up. And in the posterior pole you get dilated tortuous vessels if there is presence of pre-plus, which is less tortuosity, and plus where there is more tortuosity. And sometimes they just end at the arcades. You don't see any kind of vascularization beyond that. But if it depends on what stage you see them in and which zone it is, you have to classify them, because this is one case where you just see a picture like this and you have to take up the patient immediately for treatment. And it has to be very aggressive form of treatment. And these are the patients who, if they are picked up at the inception, they do well with lasers, but if not, we have to resort to injections.
So this is basically a slide which beautifully demonstrates to you that there's no vasculature here in between the major vessels. And this vasculature has been destroyed. It was formed first. It was destroyed by hyperoxygenation. So most of the APROP is because of iatrogenic problems. It's not really a natural course, right? So that is something we need to understand. And APROP is literally taking the eye back to the stage of vasculogenesis without too much of angiogenesis. That's what is happening in APROP. Okay?
Dr. Gopal, can you just go back one slide? I just wanted to highlight one point, that you will see this if you've not screened early. Because there is a stage of APROP much, much before this. So if you screen by 20 days, these small babies, you will see very early APROP, where the AP has not become, but you can see the loop vessels. If you treat at that stage...
I think go ahead. Next, yeah. Go next. I think we have to remember one thing, that we here already Gopal has mentioned that VEGF is a stimulus for abdominal vessels, and it is coming from this entire avascular retina, which is starting right there where you find this kind of a sort of a ridge or whatever is black is there, and all the way to ora serrata. So you need to ablate the entire retina right from here to ora serrata, all around wherever. You have this next please. So you need to ablate right from there. And of course, we have already, the next please. I think that is what Karobi has already told. It's very important that we have more number of babies for treatment now than that era of cryo-ROP threshold disease. Next please. I think this was already talked. Next. I think that is what is important. You need to deliver laser through the laser indirect ophthalmoscope. You can use, I'll show you just now, both I said earlier, some of you were there, you can use diode or 532, either of them, they don't make a difference. You use which laser you have. You don't need to require a special laser for that. And we have shown that in a study published in BJO. The plus disease would regress first like this. This picture was taken just after two weeks. So you must do confluent laser, and the vessels, the tortuosity, the dilatation disappears, they become straight like this, and 90% favorable outcome you will have. Next please. And of course, I'm not going to dwell on that. I think it was mentioned that you can treat inside the incubator, and you can screen also through the incubator if it's a sick baby, and it will be with the same parameter, and this is possible. Next please. And this is what I wanted to share with you, that we have published this in BGO in 2010. So you don't need to acquire a special laser. Even in the presence of what is here, tunicovasculosa lens, which is hemorrhage or preretinal hemorrhage, you will not damage the lens. And you will have equal efficacy as is with the diode. So in the Western world, most of the time, they were all the time emphasizing you must require a diode, otherwise you can't treat. So that's not true. So we, in our country, it's very important.
I think I'll just interrupt here. Dr. Steve Charles had a case of bilateral total cataract after laser photocoagulation done by his fellow. It's obvious that Steve Charles is busy elsewhere. He never even supervised what was being done. And the fellow probably is a novice who has not gone through the phases of training, and he's focusing more on the tunica vasculosa lentis than on the retina, and hence he deliberately burned the lens. So if you're actually focusing on the retina, the chances of burning the lens and creating cataract is far less even with a green laser, as Professor Dogra said.
In fact, I have a case with bilateral acute cataract after diode laser. In fact, we have very well documented that. I have not shown the picture. So I think what Gopal said, that is
Training.
If you focus somewhere else, and that was the same way done by my fellow, maybe there was something to it, so I don't know what happened next. And of course, I think Subhadra, I always give a lot of credit to her. She gets to the thing, and all of us, we got together and put up this article. You should go through this, and it'll give you a very good idea how you should go about doing a laser and all aspects. So that is published in Indian Journal in 2010. So next please. So this is what I wanted to show you. You gave near confluent laser and it almost shows up like this and everything straightened out. You see here, that is what is important. Next please. And this is a big baby here, so-called oxygen-induced, I would say, AP-ROP, and even this kind of ROP would regress. As Subhadra said, you have to pick up them early, and if you pick up early, even this would regress. Next, please. And this is another one. This is stage 3. Next, please. So here you may have to go back repeatedly. Next, please. And this one also, you see, it has regressed really. Next, please. And you can see it regressed, but we went 3 times back, filling every area, whatever. And here we were so scared to inject anything. You saw that it would have probably lifted up everything, so you don't want to do that. Next, please. And this is what I think Gopal was telling. We have seen these kind of huge loops. They are avascular. You have to go inside them, you have to treat them. This is in addition. Next, please. Despite that, this one here proliferated like this. We had to do lens-sparing vitrectomy, and this did well. Next, please. And so basically, I would say do a laser promptly, right from ora serrata to the ridge or inside the loops, come up to cover everything which is avascular. That is very important, and it should be a confluent laser. Very important. And don't do inadequate laser. Don't sit on that. I have not shown you all those. There are so many. There are spots put behind, few in front, and they have progressed. Even I have a case where I have shown so many times, where they have gone through the fovea, almost knocked off both the eyes. I don't know, the child is blind and grown up. What is going to happen if he knows that it has been blind because of laser? So don't do that also. I think it's very, very important. Laser is very important. Yes.
Sir, what's your opinion about posterior laser laser beyond posterior to the ridge?
Yeah, I think it's coming next.
Yeah.
Dr. Anand, I only connected 2 cases of yours because of lack of time.
So the 2 cases to demonstrate, one is this. So you've lasered and then you know you have to come closer. One temptation is to override up to zone 1 right in the beginning. It needs courage and it needs some clinical acumen. Or you want to go close by and wait for some of their avascularity to go. So a week later you do a little more fill-in spots here, knowing fairly well that if this vascularizes, the capillaries show up, they do well. This is October 20th. The mother was a VR surgeon, unfortunately, and completely lost for follow-up, comes back 2 months later with this traction. So I just go back here. So you can actually predict that if this ischemic area is left behind, this will happen. We would have filled it in on this day, but for the fact that I believe being a VR surgeon, she would show up the next week or see her baby herself. She came from another city, came 2 months later with this traction. I sent this case to both Dr. Subhadra and Dr. Dogra, what to do next. So we had options of either a vitrectomy or avascular. At that time, we still didn't even consider wait and watch or further laser. I think, sir, those slides are not there. No, those slides are not there. Okay. So basically, the mother said no for a lens-sparing vitrectomy. So we went ahead and did more laser here in this ischemic bed, and now this child is 5-6 years old, doing extremely well. The entire traction went away. So one pointer for that is if this is hemorrhagic, if this traction still has a lot of blood, it will respond to your supplement laser. It would be almost criminal to give Avastin here because it will lift up like the crunch. Either you do a lens-sparing vitrectomy vitrectomy or you do an additional laser. But if it's already whitening out, there's more fibrosis than bleeding. If the PMA, the post-menstrual age, is more than 40, then perhaps your laser may not work and it may be a case for early vitrectomy. This one we did with laser and it did very well. Now, coming to Dr. Samat's question about this posterior to the ridge laser, it's been recently, maybe 2 years ago, published by the Anna Els group. I'm just going to summarize our experience in this. So I'll tell you what's been published. So they say if this is stage 3, the traction is raised and it is now fairly close to zone 2 posterior. The recommendations are that if you look at this width of the ridge that's being lifted, about 1.5 to 2 times the width of that in your laser spots. The reason, FFA studies have shown that these popcorns and these areas actually capillary non-perfusion is unhealthy retina and deserves to be lasered. That's the rationale. So this is somewhat how you do it. This is a fairly raised ridge, otherwise almost in zone 2 posterior, zone 1 edge, and you're giving this much spot. You have to make sure that from the center of the fovea, you're at least 3 disc diameters away. This is the published recommendation. This is not yet in our guidelines, but since the question came up. Now, sometimes you get lasers like this. This is inadequately lasered, referred to you, or just hanging around, lingering around disease. This will then qualify for your secondary posterior laser. So primary is when you do it for the first time itself. You know that you can prevent the traction. And this one you do because you're forced to. So first thing to do is fill in this laser here. Do not let this anterior part go. And then because of this unhealthy laser, so you fill in and then you add it, and then they do extremely well. Now then, there will be a time when about 2 or 3 weeks later you can refill in this central area, because now this will become flat, and if you think that it's going to go away, you're mistaken. There's still nidus of ischemia there, and if you go back and fill it in, this whitened portion, then it does extremely well. So obviously the whole area heals and there's no traction at all.
Anand, you can go to the next
this
slide.
has been published by Gopal also, giving laser to the ridge area. I think this is in India probably.
Yeah, my colleague Dr. Sen, Dr. Praveen Sen worked on it. Yes. Yeah, we can. This is complication laser preparation.
Yeah, that's the next question.
I think there are two points I want to make. One is the publication by Dr. Praveen Sen, my colleague from Second Korea, also showed that we're not doing primary posterior to ridge laser. We're doing it as an addendum. Fill up everything anterior to it is not working out. We add more laser posterior.
Yeah, go back.
But I also want to point out one publication from Dr. Michael Tracy group, which came recently, where they have shown that in the cases where the avascular retina is going right up to the fovea, do you treat right up to the fovea or do you leave an area untreated? This was a question raised. They were treating right up to the fovea, and these patients were followed up periodically, and by the age of 4 years, they have taken serial pictures and they have shown that the original area which they have treated, which was thought to be going across the fovea, has actually shifted to online with the temporal arcade, which means the eye does grow posteriorly, displacing the fovea, the treated area away from the center, and you get the macula still spared from that study of Michael Tracy. Yes, Dr.
So many a times even after you laser, you see it after a week or two, you find a lot of skip areas coming up because those are the areas which have grown. So if it's still active, you generally put in a little more laser in those areas.
So this is about the complications after laser or doing laser. Yeah, so the main thing is 2 heavy spots. I think that's what Dr. Gopal was saying. Many of the fellows, they're so excited. They keep on doing more. So I tell them, if you get the spots, please reduce your power and go to no spots and then come to spots rather than trying to come down to spots, because that's very important not to put heavy spots. Put confluent, but the energy should be less. And then you can, of course, have exudative RD or hemorrhages, but this is how the color of the spots should look like, light gray. It should not be dense white. That's important. And this is one of my first lasers. You can see, in the training phase, we tend to leave a lot of skip areas. So it's important to learn how to do a good laser, and that laser should be confluent but low level, and then go back in 3 to 5 days. Don't wait for 1 or 2 weeks and see if you have skip areas. Treat them immediately, because in your learning phase you will have skip areas. And then if the traction starts, because that is one of the complications which can occur, then refer for vitrectomy very early. I delayed here and I learned that you should refer for vitrectomy very early rather than wait, because then you have very good outcomes. Very rarely you can have hemorrhage, or like we had a central retinal vein occlusion. This was published during the laser. The fellow was doing laser and patient will have CRVO. And the first thing is to blame the fellow. You might have put more phenylephrine, maybe you put too much pressure. But actually when we went back and saw this patient actually had protein C deficiency, and now I have two patients where during laser there was a hemorrhagic episode and we did protein C level. They're very low. You give them fresh frozen plasma, the levels come back. So that can be one of the reasons why there is bleeding during your laser, or there is a thrombotic event, or there is not a good outcome. So that we are learning that they can have thrombotic tendencies, and that may lead to less outcomes.
Thank you. Because in the interest of time, and just to give you an idea about the overall gamut of ROP, I'm forced to skip a few slides, although they are very important and very interesting slides in between. If time permits, if we are able to finish these two talks, then I will come back to those a little later. So I will ask Dr. Dogra to talk about lens-sparing vitrectomy. Yes, Dr. Dogra.
Yeah, I think basically, lens-sparing vitrectomy is one of the greatest innovations as far as the ROP is concerned. At least I am a big fan of that. That is what I do very often. And next, please. Next, yeah, we quickly go there. Next, please. I think next, go to the next. I think what is most important here is that you need to consult the patient. Give him a realistic expectation. That's very important. And anesthetic risk is one we at least have a big problem, especially if the baby is too small and progressing fast. So that is an issue with us still. And we must talk about the poor outcome. Visually, they are the sun of the vision in OB and stage 5. And of course, they need regular and long-term follow-up once they agree for this kind of treatment. And of course, we mostly do these days for 5G. And of course, it's ideal for 4A and 4B, maybe some early cases of stage 5. Next, please. I think what is important here is we enter, I'm not going to show you now the video here, that we enter around 1 to 1.25 millimeter from the limbus, because before 6 months, the pars plana is not developed. And you need to go down vertically. That's very important, otherwise you hit the lens. And even when you are putting the cannula, you have to keep it out. And don't keep it like this. If it hangs and touches, then it's a problem. And of course, you have a low swell rigidity. It is not as easy as you would find in endurance. And of course, you need to do first a core vitrectomy. It's very important. I had shown in the video, but we'll not, for the time sake, that you need to do this ridge to periphery, ridge to ridge, and also from ridge to lens. So there are so many, so you need to cut everything. Here the problem is you can't most of the time remove the silence. You may partly succeed in some area which might be very vital for you to do, but don't struggle with that, because you produce an androgenic break, that will be end of the surgery. But most of the cases, it's not difficult to do a lens-sparing vitrectomy in 4A and 4B. That is what I would say. Go and try to just follow these principles. Next, please. So, next, please. I will go ahead. I think we thought we skip this. And this is one such case, just taken 2 weeks after that. Next, please. This one here, you can see, this I had shown a picture earlier. Comes late to us, develops picture like that, and this is the best I could do. And this is the eye. This is the child I had shown, I think, in Hyderabad. Child went to Singapore, to Dhofar, for the other eye. Of course, this eye was a little better than that and did very well. This is lens-sparing vitrectomy done by him. And the same way, what time to do it? That's the problem. Maybe somewhere after laser immediately, because it went into 4B, you see here. And we could do some job. It became a little better, but you see, probably we have need to go for the next. I think all these things, this 4 o'clock hours, I think this is doubt issue. So nobody probably at this time, if it is a progressive traction happening, most of the time you go in and do lens-sparing vitrectomy.
Just to summarize, principles in stage 5 ROP, I'll show you the video once it comes on. But in short, we would like to say is that when we are operating on a patient of stage 5 ROP, the most important thing is to explain adequately to the parents what to expect. If they go in with high fancy ideas that they are going to get a lot of vision, you have to burst that myth and tell them exactly what to expect. Because depending on what kind of funnel you are tackling, it would either range in a closed funnel up to about 8% of success rate, and in an open funnel between 13 to 25% of success rates. So once they have adequately understood that, then you opt in for surgery. So what are the principles of this of the stage 5 surgery? First is that we always prefer to do an ultrasound, because you have to know what is the kind of funnel you are dealing with, and also to explain the prognosis to the patient, because that is very important. Then after that, come on over there. See, this is the slides which show you that this is the kind of funnel. The last funnel which you see, there's a pointer over here.
Pointed, yeah.
The last funnel over here is the closed funnel, which has the worst prognosis, and this is the kind of patient which has the best prognosis. क्या हुआ? इसका ये नहीं आ रहा है. Okay, and then the thing is that in these cases, you have to do a lensectomy to create the space. Don't be hesitant to cut off the iris at the entrance points, because they always keep getting into the way. You need to have to see the periphery properly. Relieve all the 3 levels of traction. What you see over here is the 3 levels of traction, which is anterior-posterior traction, there is a tangential traction, and there is a loop, which is an anterior loop traction. Now, it is very important that you relieve all the 3, otherwise there is going to be no success. So first you go on to the retrolental membrane, you make an opening in this, either pie-shaped cuts from center to periphery or periphery to center, and then you delaminate it all around the rim. Then you come to this part where you are going to cut this, because this is an anterior loop traction. It's like a fold, and once you relieve it, the retina is able to unfold itself and try to seek its own position. Third thing is that these kind of tractions also have to be taken care of, and if it's a closed funnel, then you have to go and open up the funnel as the last measure. Very important that whatever you're doing in the periphery, always depress from the periphery and cut it out. I don't know, this cursor is not moving. Cut it out, and after that what you have to do is that slowly go into the center, take care to avoid the blood vessels and open it up. I don't know, this is not starting, I don't know what is wrong with it. There are 3, this. Do not create breaks, because if you create a break, then the case is almost finished. At the end of the things, to relieve it, you just inject Helon, and the thing is that you can top it up with a little air in the anterior part. If the exudative component is a lot, then you can go and do a needle SRF drainage or a simple SRF drainage. And no dynamic settlements are done in these patients. That is, if you find that the retina is well released, just leave it. This is, the retina will go and seek its own location, and the period within which this can happen can range between 3 to 6 months. So you have to have patients follow up. But if there are any, avoid any inflammatory episodes in the post-operative period, or if there are bleeds, these alter the prognosis, because once the folds form again, it's like we generally, only in 5% of cases, we go ahead and reoperate on patients of ROP. I don't know, the videos are not running, so I'm very sorry, but I think I'll conclude it at that.
Thank you very much, Dr. Karobi. Just one last sentence that we could not cover one important subject, anti-VEGFs. That would have been again a very important discussion, but unfortunately time didn't permit. Only with one sentence I close it. I'll ask Dr. Subhadra to make the sentence about anti-VEGF.
I would say that, anti-VEGF, look at it as a new treatment, evaluate it. If you're using it, understand the drug, understand what it's doing, what it's not doing, what are the reports, keep up with the literature, and then make your decisions.
With this, I would like to thank all my colleagues and co-panelists, Dr. Karobi, Dr. Dogra, Dr. Anand, and Dr. Subhadra, and the excellent audience that we have. There is a hands-on camera available. People who want to try it out can please try the RedCam camera. Thank you very much.